Hello, I'm Dagny, Medical Director at Envision Eye Centers in Rowland Heights, California. Today I'm joined by Dr. Nicole Fram, who is Managing Partner at Advanced Vision Care in Los Angeles, California. Hi, Nicole. Thanks for joining. How are you?
Good. Hi, Dagny. Thanks for having me.
Awesome. It's an honor to have you. So, in this episode, we're going to be talking about advances in surgical diagnostics and intraoperative guidance systems for improving cataract refractive outcomes. So, let's get right to it. So, as you know, intraoperative aberrometry is a guidance system we've used for a while now with cataract surgery, and you're one of the first to use it, and you've had a lot of experience with publications and things like that. Can you tell us how you've been using it nowadays and anything that's changed? What's new with intraoperative aberrometry?
So, intraoperative aberrometry is an intraoperative device that initially you put some of your biometry data into, so your axial length, your Ks, your white to white, and actually that information goes into a Holiday Virgins formula that has, instead of having ELP as an optimization, it actually has an aphakic refraction that then optimizes your outcomes. So you basically get the eye pressurized to a certain extent. You have a wound that looks good and is not overly hydrated. And then it kind of reads, it bounces light in, and through wavefront aberrometry, the light comes out and gives us a power that's been estimated by that refractive Virgins formula and the optimization of the aphakic refraction. So in essence, it's giving you a predicted IOL power. The problem with intraoperative aberrometry is that if your cornea is dry or you're overhydrated, you could have some outcomes that were not ideal. But if you follow the guidance of how to use it, it was extremely helpful in our practice. And in fact, we did it in almost every case because we could actually check our outcomes by, the aura analyzer. So by using aura and the analyzer, we could go back and say, how are we actually doing with these lenses and what's our outcome? Is particularly helpful in high torics and particularly helpful in post LASIK. And I still use it in those circumstances. And the reason why is that it was my first experience with big data. So this Aura system has over 1 million inputs in it. And so it's constantly optimizing, whether it's a global optimization by doctors putting back in their refractive outcomes to optimize things, or it can be a personal optimization, which makes you even more accurate. So it's a great way for me to search these eyes afterwards and see how I'm actually doing. Now we have new AI formulas and other ways to do this now with other software planning systems for cataract surgery, but I still find that intraoperative aberrometry is very useful in my high torics and post LASIK patients.
So I know a lot of surgeons have commented about how noisy it can be sometimes, and they're not sure what to do when it doesn't match their biometry predictions. Like, how do you use it as a tiebreaker? And what are some quick pearls that you like to share with surgeons on how to best utilize Aura to get more accurate?
Yeah, I think that you said the magic phrase, which is tiebreaker. So it's not a deal maker. It's a deal breaker. And so I go in, I say, this is what I'm willing to accept. If I have two biometers, I'll look at, typically it's Barrett Hill RBF. I like to use an AI-based formula and a Virgins formula. And I look at both of them, and the cane is also great. And I say to myself, okay, I'm in between two lenses. This is what I'm willing to accept. And if I do Aura and I see that it agrees with those two other formulas, I'm feeling really confident. I'm feeling really good. If it's way off the mark and I know that my lid speculums, it's a small eye and I opened it up too tight, if the corneal incision's overhydrated, if the patient can't fixate, I'm obviously not going to use it. And so I think a lot of the people that said, I don't need Aura, it doesn't work, are people that don't want to take the time to make sure that these parameters are set. And I would never choose Aura over my biometry if I had two formulas on two different biometers saying the same thing and Aura said something a diopter different, I would never switch to that. So you have to use it enough to know when to not believe it. And that's the hard thing. If you only use it once in a while for a post LASIK case, you're not going to have the skill set to know when to believe it or not.
Awesome tips. Yeah, definitely. Ultimately, it comes down to your clinical judgment evaluation of everything as a whole, right? So you talked about some of the other imaging guidance systems that you use, or we talked about it earlier. What are some of the other diagnostics or imaging guidance systems that you like to use, and how do they improve your cataract outcomes?
So we're so lucky to be finally in the stage where people are using reference images that are going into software planning systems that then go directly into our microscope. And then we can see it overlaid on the eye to find the steep axis. So, for example, if I use an IOLMaster 700, that reference image can go right into a software planning system, Veracity, that can then go into a Callisto in the microscope and then overlay where the steep axis is. Now, this is only taking in consideration steep axis, not magnitude and anterior and posterior corneal contributions. That's where intraoperative aberrometry sometimes wins, is that intraoperative aberrometry is a total aphakic refraction. So it takes into consideration your posterior corneal contribution. So, but back to having the overlay of the steep axis is wonderful. And it technically means that you may not have to mark in the preoperative area. I always mark because I have had times where I get into the OR and the reference image isn't there. And so I don't want to sit the patient back up and mark them after I've realized that. So I think it's your parachute to always mark in the preoperative area. There are other platforms with the Argos system where the Argos biometer has a reference image that goes into either a microscope or a DMM, and that can go into, it's a Varion image guidance system that'll go into your Ingenuity if you're using heads-up display. So I use that as well. And that is just, the Ingenuity, the new 1.5 is magical. I can see things that I never thought I would see before. So that's been a huge boost in our practice because now we know where we're putting things. And then you can use certain different platforms on femtosecond lasers that actually put capsule tabs that are in the actual capsulotomy, and you can line your toric up with that. And that's image guidance also from either an IOMaster 700 or a Pentacam or Cassini and things like that. So it's a really exciting time because we can actually make sure intraoperatively that we're on the steep axis. When you look at rotations and issues with residual astigmatism, a majority of it is improper placement at the time of surgery. And we keep saying it's rotating, but we probably put it in the wrong place.
Yeah, all great points. I also love using iris registration for not having to mark the eye and to better align the toric lens when it's matched with my femtosecond laser created capsulotomy. I really like that notch is there and it's using iris anatomy. My understanding is that Varion and Callisto, it uses scleral limbal vessel. So I think sometimes there are some issues sometimes with chemosis or things like that where it can maybe obscure some of that. How often do you get sort of issues where you rely on your manual markings?
So I love how precise you are because certain platforms of femtosecond lasers use iris registration, and that's Catalyst and Lensar. And certain platforms of digital marking use scleral vessels, and that's the Varion and Callisto. And what's so great is that I'm so spoiled in my surgery center that I can use a Lensar and go right into my OR and then use a Callisto. And it's I feel so good when I have scleral vessels that are saying the same thing as the iris registration, right? So I don't have my big issue with digital marking and things not registering is that the person that did my biometry data didn't send over the reference image. It's not what's happening in the OR. So we're not seeing that kind of breakdown from chemosis or subcontium.
That's awesome. I love how advanced your OR is with all the bells and whistles. So I think we're both have on our wish list another intraoperative diagnostic or imaging system, which is intraoperative OCT, which will actually allow us to see perhaps one day in vivo, in real time, what's going on during surgery. How do you think that will help us with our cataract surgery outcomes?
So there's been some really incredible publications on this. I think, the retina doctors have shown us that intraoperative OCT with epiretinal membrane peeling can be very beneficial. But what does it do for a cataract surgeon, an anterior segment surgeon? There's some great papers that were presented at Academy and ASCRS on looking at posterior polar cataracts and understanding where you actually are in the eye and how to protect the posterior capsule. So I do think that that can be an advantage during surgery. If you're doing complex surgery and doing intrascleral haptic fixation, being able to tell on the table if there's significant tilt, I think will help a lot of patients in the future with potential for UGG syndrome or inflammation and pigment dispersion. And then lastly, I've used intraoperative OCT during corneal surgery. So for DULC surgery or particularly for DSEC, a lot of this times we're doing DSEC now on the most complex eyes, and we want to make sure there's no fluid in the interface. And, seeing that, kind of massaging or tamponading that fluid out is just one of the most satisfying things I've ever done in my career and using intraoperative aberrometry. But maybe that says something about me.
No, definitely. I get that same feeling. And along the same lines, I feel like being able to identify a Decimase detachment early on during cataract surgery is really helpful to have intraoperative OCT as well. So you're not further aggravating that and causing an issue. So I actually, as a refractive surgeon, I actually find intraoperative OCT to be very helpful from a refractive standpoint, especially when it comes to ICLs. So right now, it's a little bit difficult still to figure out that ideal ICL sizing. And being able to insert the ICL and see what kind of vault you're getting with that patient's anatomy and know whether you have to exchange to a smaller or larger size would be extremely helpful. And I know some surgeons, Dr. Zaldivar in Argentina, they're already using intraoperative OCT for that purpose. So it's very exciting. Hopefully we'll be able to get access to that here one day. But speaking about refractive surgery, there are some other imaging diagnostics that we can use to better improve our screening of refractive candidates. For example, OCT of epithelial thickness or epithelial thickness mapping. So Nicole, how are you using that? What sort of benefits do you find that provides you for your refractive or even cataract patients?
Yeah, I started using epithelial thickness mapping many years ago when OptiView first released it. And the main area that I use it in is, sometimes you have a refractive surgery patient come in and there's asymmetry of the anterior corneal surface, and you're trying to figure out, is this really an ectatic patient or potential for ectasia in the future, whether it's keratoconus or post-LASIK ectasia, or is it actually contact lens warpage or something of that sort? And so what I use it for is there's a mapping of the pachymetry, and then next to it is the actual epithelial thickness. And the total pachymetry in certain areas you would expect where the pachymetry is thin and where the cornea is steep, the epithelium should be thin. And if the epithelium is thick in that area, then this is actually most likely an area that has contact lens warpage. However, if the area of the epithelium is thin, where the cornea is thin and steep, then you're really thinking this patient may have a potential for ectasia.
Yeah, same here. I think we can never have enough technology to better refine our screening abilities. And often I need that tiebreaker, similar to what you use Aura for. I use epi mapping as a tiebreaker of whether I can safely perform corneal refractive surgery in a patient or not. And very often I've seen that, suspicious inferior steepening, but I don't see a corresponding posterior elevation. And then when I look on epithelial thickness mapping, oh, that area that was steep is also thick. The epithelium's thick there. So then I'm comfortable knowing that, okay, this is probably not ectasia, it's probably contact lens warpage. So I totally agree.
Yeah, and then you just tell them stay out of your contacts for another week or a couple weeks so you can make that decision. But it is a nuance, but it's a nuance that has changed my practice.
I would say the only other way that I use it, maybe for cataract surgery, is to identify those patients with really subclinical EBMD. Like sometimes I'll miss it on slit lamp exam, but their epithelial map will just look totally warped, like areas of thinning, thickening, and often those are those are patients who would benefit from superficial keratectomy before surgery. So that's another way that I use it.
Yeah, I think that's really useful in a patient. I sometimes have these EBMD patients that, their placido imaging looks okay. And, epithelial basement membrane dystrophy, it's kind of like a heartbreak when you see them because you're like, oh no, you're not going to be like your friends. Like you have to be polished. I don't say scraped. You don't say, hey, scrape. That's not nice. So you have to be polished and then we have to wait 2 months. And oh, by the way, you're gonna hate me for a week. And so I think in those patients that have normal placido imaging, but you can see the EBMD paracentral, I would think that epithelial mapping would be very beneficial. So that's a great point.
Yeah, and then you can kind of monitor them for stabilization as well. So finally, this brings us to the conclusion of our discussion. What are some upcoming diagnostic or imaging guidance systems that you are looking forward to having and you think will improve our refractive outcomes in cataract surgery?
This was a tough one for me because I feel like I have every toy I could ever want right now, except for intraoperative OCT. I want that one. But I would say that the technology that I'm most looking forward to is adjustability after the surgery, because no matter what we do and how we plan, there are going to be surprises. We have residual astigmatism even when we put it on the right place because sometimes there's IOL tilt. We learned that from the Baylor group. We have dry eye and ocular surface issues that sometimes when we do our biometry, we still may not be right on target. And even with the best formulas, we're 85% to some, you know, some formulas quote 91%. Yeah, on target. But post LASIK is, still 78, 79. Maybe with the Barrett True KTK, we can get into the 81%. So we are still not at 100%. So it's the adjustable technology after surgery. And so we have that with some light adjustable lenses, but also, the perfect lens, being able to take people that weren't on target and change their lens after surgery, provided that, the contrast sensitivity and MTFs remain. That's a technology that I'm excited about. So I think we have a lot of interesting and amazing technology as it stands right now. But my biggest, excitement is really about adjustability in the future.
Yeah, I'm totally looking forward to that as well. I was at AAO recently this year, and I did get a little sneak preview of what we have coming, at least in the near future, for intraoperative imaging. And it seems like the trend is heading towards getting more out of our, display, our microscope display. I mean, you have Ingenuity, so you might have all these features already, but being able to look in the microscope and know exactly what power IOL we're going to place so we don't get those errors. You have everything talking to each other through the cloud now, so we minimize some of those transcription errors. And then also just overlays over the eye itself of where you should, place your incision, your main incision, and how large or where you should place your, capsulorhexis, things like that.
We have those currently with Varian and Callisto. The idea that you can use lens thickness and have triggers of when you're too close to the posterior capsule, I think those things will be very cool. That's probably, coming sooner than we think, and the possibility of robotics. But we don't want to put ourselves out of business yet.
Awesome. Well, thank you so much, Dr. Fram, for the excellent discussion. Thank you all for listening. Please remember to take the post-testing evaluation to receive CME credit and tune in for additional episodes within the podcast series. Thank you so much.